screen, we will have this webinar with a similar structure that we used in the previous one. So every webinar will be the same structure. In the first block, we will have amazing presentations with an update about the different topics. And we will have 4 fantastic speakers that will update us about indication and outcomes in surgical hip dislocation by Michael Wettstein. Another talk about the role of PAO actually by Steppacher. Then the current long-term outcome in hip arthroscopy by our Canadian friend Femi Ayeni. And finally, Dr. Vikas Khanduja from UK about the new technology in preserving. We'll have after that a huge discussion, and now I try to invite you to send questions, and we will read your questions and ask the speaker your question. Please participate in the webinar with your questions and any other comment that you want to include. After this first block, we will move to the very funny crossfire between 2 guys. One is Marc Tey and the other one is Nicola Santori. And I'm sorry about that, but it's the same as the football match of the Euro Cup that we will have later on this night. So Italy against Spain. So we will fight about the preserving surgery in moderate osteoarthritis. Marc Tey will be in favor, so Spain is in favor, and Italy is against. So we will have a very nice discussion after that, and you can vote the winner of this crossfire. It doesn't mean that they will be the winner of the football match, of course. So at the end, we will have our speaker from Portugal, Pedro Dantas, that will present a case with some questions inside the case that you can vote the best option. And there will be a very nice discussion between the faculty as well. So this is the structure. I hope you enjoy this fantastic webinar about hip preserving surgery. And we will start the first block with the first speaker. So Michael Wettstein will talk about this surgical hip dislocation update. Michael?
So thank you everybody for listening to this webinar. It's a pleasure to speak about this topic, which is very interesting and gains more and more interest in the population. Surgical dislocation of the hip was described beginning of the 2000 years, needing a digastric osteotomy of the trochanter major, which we would do in a Z-shaped fashion now. Which allows for a safe dislocation of the hip to have an access to the full joint. Now, surgical dislocation allowed the description of femoroacetabular impingement concept, development of the treatment principles, and was progressively used for other intra-articular pathologies, and was considered to be the gold standard of treatment until 2010 approximately. Now, hip arthroscopy has developed in parallel with progressive techniques between the years 2000 and 2010, was considered as being less invasive, allowing faster recovery and a quicker return to sports, and has become the new gold standard for treatment of FAI and other hip pathologies. Now, in 2024, are there remaining indications for surgical hip dislocation, seeing the development of hip arthroscopy? For me, FAI with extensive deformations, mainly posterior acetabular rim deformations, even if there are papers speaking about the possibility of doing this with a hip scope, remain for me better accessible with a surgical hip dislocation. Also, deformations of the femoral head, which go lateral, or deformations of the posterior femoral head are better accessible with a surgical hip dislocation. For instance, if you have a circumferential acetabular ossification, as in this case, you see the resection of the rim, and the possibility of doing a labral graft, which is possible by scope. But if you do a circumferential capsulotomy for doing this by scope, I don't know if this is less invasive than a surgical dislocation. Also, if you have a deformation of the head, as you see here posterior, which leads to a lesion of the posterior labrum, this is perfectly accessible with a surgical dislocation, which has the main advantage that you can probe the head, which you can't do with an arthroscope. This is the final result. Also, if you have major extra-articular deformities, as the tuberculum tertium, for instance, which was described long ago, but not considered until recently, which can provoke an extra-articular impingement. This is not accessible by scope unless you do a major dissection, which finally comes similar to a surgical hip dislocation. If you have cartilage lesions, as in this young lady, you see the cartilage lesion here on the head. I don't think you can do this by scope easily or as well as with a surgical dislocation. If you have a fracture of the femoral head, as in this case, you see how it looks like with the marginal fracture of the posterior acetabulum. You can access this with a surgical dislocation, not by scope, and this remains an excellent indication for a surgical dislocation. This paper was recently published by the Bernese group, treatment of avascular necrosis in young patients with bone grafts, showing good results at short-term follow-up. But it's interesting. It gives some possibilities you don't have otherwise. Complex deformities, as is in this case, this was a young lady, multi-operated for hip dysplasia, acetabular surgery, 2 femoral surgeries, finally with a retrotorsion of the femur, head and neck deformity, cam deformity, and shortening of the leg. I think the possibility of a surgical dislocation, which gives you access to the head to correct the cam, do a relative neck lengthening, transfer the trochanter, and in this case also with the morsure osteotomy to regain the length and the offset, is an excellent approach. This is the final result. Now, remember this paper, which is important for me, to consider where is the deformation of the proximal femur regarding the torsion. This is important because depending on the location of the deformation, you will do the correction in different places. The neck, of course, needing a surgical hip dislocation. There are papers speaking about the possibility doing it with an anterior approach, but I feel this is less safe regarding the control of the vessels. Now, if you have major femoral head deformities, as in Skiffy or coxa magna after Perthes, of course, this is an excellent way to be done with a surgical hip dislocation. Iatrogenic deformities, as in this case, a patient who was operated outside by with a hip scope, with an over-resection of the femoral head. You see here major adhesions, and the correction, you can't do this by scope with a bone graft of the head. You see the final result. This was the first resection, and you see the shape of the femoral head here after the correction. Tumors, chondromatosis, with clusters of chondromas, huge chondromas. It's better accessible with a surgical hip dislocation, and of course pigmented villonodular synovitis if you have a diffuse disease or posterior disease, as in this case. You see here the nodules around the femoral neck impacted to the head. This is not accessible with a hip scope. What are the results? Improved joint function, of course. The survival depends on the condition of the cartilage, the indication, and so on. But the Bernese group showed an 80% survival at 10 years without total hip replacement or progression of OA in femoroacetabular impingement. The question if we can delay progression of osteoarthritis is still open. Now, the predictive factors for failure are patient factors, the age, the BMI. It's up to the diagnosis. You have to have the right diagnosis and do the right correction, meaning the right indication. And it's also a question of quality of treatment. Don't overtreat, don't undertreat. Complications exist with surgical hip dislocation. Minor complications, of course. The main complication is pain on the trochanter, needing the removal of the screws. It's a second surgery, but finally, this is not really a complication. It can happen every time you use hardware. Influence of rehabilitation. This paper recently published by Christoph Philopoulos from Geneva is very interesting, showing that the rehab regarding the muscles is quite long, and finally not much longer after surgical hip dislocation than after a hip scope. Surgical hip dislocation you see on this graph regains interest now. It lost interest end of the 2010s, regains interest now because we feel that there are some remaining indications. So do not believe in surgical marketing. Everything is not accessible with a hip scope. Each technique has its good indications and results, and as hip surgeons, I feel we should choose the best tool to achieve our goal. So in 2024, surgical hip dislocation remains a remarkable tool to treat hip joint pathologies. Thank you.
Thank you so much, Michael. Amazing talk. So let's continue with the next speaker. Unfortunately, Dr. Simon Steppacher from Bern cannot join because he has a last-minute problem, but he sent us the fantastic presentation pre-record. So please go with the video.
Good afternoon, ladies and gentlemen, and welcome from Bern. I apologize that I'm unable to give a live presentation. Therefore, my recorded presentation about the role of PAO nowadays, when and how to do it safely. The periacetabular osteotomy has first been described by Ganz in the 1980s and is characterized by the integrity of the posterior column and its high potential for acetabular reorientation. It has become the gold standard for the treatment of hip dysplasia, and since the description of femoroacetabular impingement, it has also been applied for the correction of acetabular retroversion. Occasionally, it's also used to correct hip protrusion, to decrease the lateral coverage and increase the deficient medial coverage of the femoral head. A predictor for good long-term outcome is age at surgery. Patients aged less than 20 years have a survival rate of hips of 75% at 30 years. This drops to less than 20% for patients exceeding 40 years. Another predictor is joint degeneration. Hips with tennis stage 2 or 3 have a survival rate which drops to less than 20% at 15 years follow-up. The following possible complications for PAO have been reported in literature. It includes injuries to the ischial or femoral nerve or vascular injuries. It is important to drape the leg so it can be freely moved and controlled during surgery. Following the modified Smith-Peterson approach with detachment of the inguinal ligament and the origin of the sartorius muscle, the space distal to the joint is prepared. The first osteotomy is the osteotomy of the ischium, which is in close proximity to the ischial nerve. This osteotomy is best performed with a curved chisel, a depth of 4 to 5 centimeters, aiming proximal in the posterior column behind the joint. This is a cross-section of the ischium showing the ischium osteotomy, first performed centrally, then aiming medially, and finally aiming laterally. The last step puts the chisel in closest proximity to the ischial nerve. A study by Birke could show that the ischial nerve is closest to the ischium in pure flexion. In combined flexion, abduction and external rotation of the leg, the ischial nerve is most distant to the ischium, which therefore is the preferred position to perform a PAO. During surgery, the leg is put on a leg holder in slight flexion, abduction and external rotation. In addition, a hand is put on the foot to feel for possible foot movement due to nerve irritation. For the second osteotomy, the osteotomy of the pubis, it's important to have good muscle relaxation and some flexion in the hip to decrease the tension on the femoral nerve and to mobilize the femoral vessels medially. These structures are protected by the iliopsoas muscle. Other possible complications include the avascular necrosis of the acetabulum or an uncontrolled fracture of the posterior column. The third osteotomy is performed at the level of the anterior superior iliac spine. The fourth osteotomy runs distally, preserving the posterior column with a thickness of 1 to 2 cm. This ensures a sufficient distance between osteotomies and the blood supply to the acetabulum. Up to now, there has not been a case of avascular necrosis in the current patient series. Finally, the acetabulum is mobilized with a controlled fracture, which bears the risk of a fracture of the posterior column or an interarticular fracture. Here a case with acetabular retroversion. During PAO, an intra-articular fracture occurred, which was verified with a CT scan. Revision surgery included reduction of the acetabulum in its original position with fixation and rim trimming as an alternative treatment for acetabular retroversion. Finally, secondary impingement has been reported as a possible complication following PAO. At long-term follow-up, impingement-free range of motion was associated with superior survival rate compared to hips with impingement due to a cam-type deformity or retroversion due to suboptimal reorientation of the acetabulum. The modified Smith-Peterson approach allows direct access to the joint capsule with capsulotomy for possible offset correction to compensate for the decreased range of motion following PAO with increased coverage, for example in dysplastic hips. Acetabular reorientation during surgery should be verified either with a pelvic radiograph or fluoroscopy. Another case with acetabular retroversion. Correction was verified during surgery with preliminary fixation and a radiograph. However, there was a different tilt during surgery with more retro-tilt indicated by the increased size of the foramen obturator. Following surgery, pelvic tilt changed again with less retro-tilt and a comparable size of the foramen obturator compared to the preoperative image. Therefore, there was partial acetabular retroversion not corrected by the surgery. Vuillemin could show that there is more retrotilt during PAO or directly following surgery with the patient still under general anesthesia. If this effect is missed and the imaging is not adapted during surgery, correction of acetabular version can be incomplete. In conclusion, the periacetabular osteotomy has a high potential for acetabular reorientation in dysplasia or retroversion, and the complication can be minimized despite the complexity of surgery. Thank you for your attention.
Thank you so much, Simon. Fantastic presentation. We can discuss at the end. Please send your questions to the chat and we can discuss later on. So our next speaker in this national team playing in this football Euro Cup is coming from Canada. So it's not European, but it's like European. So it's my friend Femi Ayeni that will talk about the current long-term outcomes in hip arthroscopy.
So, thank you for having me. I appreciate all of you. And like Oliver said, it is very European in Canada. Our official languages are English and French. And so amongst many of the similarities, we are happy to join you. And I am happy to join you virtually. Oliver tasked me with speaking about some long-term outcomes in hip arthroscopy. So I'll give you my best regards. I'm currently in surgery, so I may not be able to join the discussion, but certainly happy to present today. So here are my disclosures. I think it's important to mention that there's been a dramatic rise in FAI evidence, and arguably it may be the most evaluated condition and procedure in arthroscopic surgery if you look at the trends over time. That is because as we get better in research, there's more skepticism, which is healthy, to question the effectiveness of the operation. And in this analysis, you can see the growth of publications, and you can also see that it's been really led by a combination of North America and Western Europe. Also in this same publication, you can see the mapping that when you start to chart what is popular and what is most reported, femorotabular impingement, hip arthroscopy, and then osteoarthritis, and the relationship between those conditions has heavily reported upon and been investigated. So there's something about the publications that are increasing, but also trying to ask, what is the relationship with osteoarthritis, and also what can arthroscopic surgery do? So I think it's important to recognize that there's been an exponential increase in FAI surgery, and it's been driven by industrialized nations. And certainly there's a significant global variability in what we're doing. And then the curve on the right, where you see that bell curve, that is typically what you see in how people adopt technology. On one side of the curve, you have those who are very innovative, and then you have the early adopters. And then eventually you get to the middle, where you have majority of people thinking arthroscopy is effective, and then eventually the skeptics come towards the end. And right now, we're probably in that third column, where majority of people do recognize that hip arthroscopy has some utility in addressing hip conditions. However, there are still some skeptics who are looking at the procedure and how effective it could be. Likewise, on the very top of each column, you could see what we're looking at as far as research. On the very top, you have few case reports. After that, you look at the procedure development and exploration, some short-term studies. After that, you get to procedure assessment, some early randomized controlled trials, which I'll speak about. And then eventually, you get to that last column where you have some long-term studies. So hip arthroscopy and FAI surgery is following that consistent pattern, from early case reports to short-term studies to randomized trials, and eventually getting into the registry and longer-term studies. So here's the evidence with regards to physiotherapy versus surgery for FAI. It's been well studied in 3 randomized controlled trials. And if you look at the outcomes from the UK Fashion trial, the FATE trial, and the Mansell trial, you can see that 2 out of the 3, the Fashion trial and the FATE trial, had significant benefit for FAI arthroscopic interventions compared to physical therapy. The Mansell trial did not. It had a smaller number at 80 compared to the other ones, and a significant number of patients did cross over after completing their therapy into the surgical arm, which is a limitation of that study. That being said, we proceeded to do the first trial, which is the surgical trial comparing FAI osteochondroplasty to arthroscopic lavage. And you can see we did collaborate with our European colleagues once more in Denmark and Finland. We published on this study because we looked at how effective is correcting impingement compared to no correction of impingement. And we found that there were more reoperations in those who had a lavage, almost 20%, compared to those that did not at the 1-year point. They all increased quality of life scoring and other metrics at 12 months, but the reoccurrence and the failures were significant as you got into that second year. So what about level 1 evidence? We all know that as you look at the evidence and you grade them, level 1 is typically a systematic review of randomized trials, and level 4 are the case series which we're now moving away from. And in this systematic review, looking at the evidence for randomized trials assessing FAI surgery, once more, when you pool all the data in a systematic review and you meta-analyze them by combining data, you see that there's a significant report of greater improvements in hip function, health utility at 6 and 12 months postoperatively for those treated surgically compared to those who are not. In this paper we published a short term ago, we also looked at 10 studies looking at FAI outcomes, and there were fewer revisions at 2 years if you complete a femoral osteochondroplasty. We had a report of greater improvements in symptoms compared to those who underwent hip therapy. In female patients, a labor repair led to better improvements compared to those who did not and had debridements. And navigated osteochondroplasty did improve the alpha angle correction. So this is once more pooling the world's best literature, the best of what we have, to give us some information as to what could be working. As I mentioned earlier on, the next step after randomized trials are registry-based data. And luckily, we have the Europeans leading this way with the British Non-Arthroplasty Hip Registry, the Danish registry, and other registries that are also being conducted all over Europe. But these two certainly have the longest track record and have been very helpful. You could see that the recent publication of over near 5,000 patients in the KSSDA journal, that 2/3 of patients achieved the minimum clinical important difference. And that was quite substantial. And it also did show that hip arthroscopy is an effective surgical treatment for patients undergoing FAI surgery, with significant improvements that are maintained at the 12-month follow-up. So we're now seeing that, yes, we'd like to have perfect outcomes, but at least 2/3 of our patients are improving with the interventions we do conduct. The Danish registry did have an updated report of 5,333 procedures, and looking at 5-year outcomes for over 383 patients, or for 383 patients, you do see a significant reduction in pain and disability when you compare to preoperative status. So although there's a significant drop-off over time, which is a limitation of registries, because as patients get better and move on, it's hard to bring all 5,000 patients back. Certainly at 5 years, a substantial amount of patients are still having successful results with surgery. Now, what are we doing in North America? Well, we're learning from our European colleagues, and we're also trying to get better at capturing data and learning from the experience of the United Kingdom, as well as the Danish experience. We are now starting the North American Hip Registry called HIPSTER. And this is the board and the membership of this group. And we're collaboratively trying to do what you're doing in Europe and accumulate data across the continent of North America. And these are the schools that are currently involved in collecting data. So it's starting to really expand across jurisdictions in the United States and Canada. And we are collecting time points, as you see, at 3 months, 6 months, 9 months, a year, 2 and 5 years, and then 10-year data. So this is the next generation of studies looking at long-term data, is taking these 5 and 10-year outcomes, studying them comprehensively, and in the database, starting to get some really good prognostic information as to what could be effective for surgery. I think it's also important to talk about natural history, which is very important. I don't know what happened to my screen there. I'll pause my share. But in natural history, we're starting to see some studies that are showing that 25% of patients who have FAI surgery using modern techniques may have a significant reduction in progression of arthritic disease. So we are now seeing the impact of FAI surgery on natural history, which is quite important. So that being said, I would say that although not every patient does reduce or is prevented from having osteoarthritis, we may be starting to see with these longer term studies the impact of all of our work on the natural history from this study from special surgery. In this study, patients had bilateral hip FAI, and the surgical side did not progress in 25%. So it certainly is an impactful level of care and involvement if you can at least help a subset of patients, apart from getting symptomatic improvement, also not progress with regards to osteoarthritis. So overall, I think people ask, well, what makes FAI surgery acceptable? And we try to look across the world to figure out what we should be doing better. And in our 2-part study, and many of those on this call and on this meeting were involved, we tried to develop a Delphi-based study to look at what should make FAI surgery, as far as correction, optimal, and how can we improve patient outcomes. And we went across jurisdictions, worked across the world, and had a Zoom-based conversation and discussion and voting for these things. And we looked at our key findings, and here's what the world's best and world's most comprehensive dedicated surgeons came up with. Fluoroscopy and dynamic assessment can be helpful. The done lateral view and AP views can be very helpful postoperatively to assess whether or not you've done a reasonable and accurate correction. Evaluating sphericity for cam-type impingement and dynamic testing is important. Eliminating or reducing some of the focal crossover can be helpful in pincer-type FAI. The lateral center edge angle is important to assess for global overcoverage, and avoid overcorrection in the pincer-type FAI because that is deleterious. So I believe that as we're moving forward with evidence and research, certainly level 1 studies are supporting hip arthroscopic intervention for FAI surgery. Big data from registries will refine our collective understanding, specifically of prognostic factors, and the natural history and survivorship data will be our next focus. And we are already seeing information that we may be starting to impact the natural history of arthritic disease. So I'm very grateful, and I thank you for the opportunity. Thank you.
Thank you, Femi. Thank you, our friend from the other side of the Atlantic Ocean. So I really appreciate that. And you are invited to come to Europe and maybe live with us at any time. So thank you for your effort, Femi.
I appreciate you. Thank you.
Thank you. So let's move to the next talk. Is the last talk of this block. Is our friend from UK, Professor Vikas Khanduja. I know England is doing a great role in this Eurocup, but your role in this session is to tell us the update about new technology in preserving surgery. Vikas?
Thank you very much, Oliver. And many thanks indeed for the kind invitation. So the focus of this talk is using technology for hip preservation surgery. Bring you greetings from our biomedical campus in Cambridge, which is ever expanding, and would be delighted to host you if you do wish to visit us. We have a fairly large clinical service servicing pretty much the whole of east of England and parts of Northern Ireland, and also a good research group with 6 PhD students. And you'll see a lot of their work presented in this talk. So big thanks to them, and also a couple of MD students and 2 MPhil students as well. These are my disclosures, and none of them are particularly relevant to this talk. So if you look at technology, then the whole aspect of hip preservation surgery, right from training to preoperative planning to intraoperative execution and postoperative outcomes, is where technology can be useful, is being used, and there is enough research going on in this arena, both in our labs and also labs around the world. So if you look at training, we're looking at augmented reality, virtual reality, and simulation. If you look at preoperative planning, then we're looking at stratification of disease with automatic segmentation of CT scans, collision analysis, and discrete element analysis. Looking at intraoperative execution, there's navigation and robotics. And then postoperative outcomes, we're looking at AI for predicting outcomes, and physio tools for delivering physio and monitoring compliance as well. So it's the whole gamut of hip preservation surgery that will have a technology involved in it. And I'll take you through bits of this. So let's start with training and virtual reality simulation. So you've got both fairly high fidelity simulators, low fidelity simulators, and augmented reality as well. So we looked at the construct validity, face validity, and the learning outcomes with this high fidelity simulator. So the first set of experiments we did was basically subjected experts versus novices to basic visualization, that is 21 targets through 3 portals, and probing targets, and 8 and sustained contact, to basically look at the construct validity of this virtual reality hip arthroscopy simulator. And what we found was that the novices did not do as good as the well-trained hip arthroscopists. That implies that the skill in the operating room is reflected in simulator performance, and it validated the construct validity of this specific simulator for that module. The next thing was to look at face validity. How real is it? So we checked 7 domains. 92% found it non-threatening learning environment and enjoyable experience. Over 80% found it to be a useful training tool for interns, residents, and attendings. But the issue was that tactile feedback received from the soft tissues was not ideal, only about 52%. That was the main limitation. So although it has face validity, the tactile feedback is a major issue. The next thing was looking at learning curves. So if you practice this on for 7 to 8 weeks, would you improve as a surgeon? And clearly we basically invited 25 medical students for this, and they practiced on the simulator for about 7 weeks, and definitely their skills improved. So learning curves were improved as well in this. So those are the 3 things that we did with this specific simulator. But obviously, simulators or augmented and virtual reality programs like this are now available, which allow you to learn hip arthroscopy. So we gathered all the literature and we basically tried to find out, does virtual reality simulation have a role in training trauma and orthopedic surgeons in this article? And essentially the sound bites from that article were that it's a great adjunct, but haptic feedback is an issue. It's probably more useful for earlier stages of training rather than later stages. And we really need to be a bit more critical with our evaluation of this technology. And we need to establish utility before spending thousands and thousands of pounds on actually buying these simulators. And therefore, collaboration with the companies who are developing this and testing them to establish utility is the key. So that's as far as training AR, VR is concerned. The next thing is let's get on to the operative aspect, both preoperative planning and intraoperative execution. So now if we look at the non-arthroplasty registry in the UK, which Femi has already alluded to, you've seen this paper. We've got around 5,000 cases in this paper. We analyzed them for FAI surgery. And essentially what we see here is that 2/3 of the patients are achieving MCID, and only half of them are achieving substantial clinical benefit on the IHOT-12 score, which is worrying because we think, or we would want, that 90% or more of our patients, or every patient that we operate upon, should be achieving their MCID and substantial clinical benefit. The worrying thing is that about 1/3 of the patients are actually not achieving their MCID and probably worse after the operation. So this red bit and this orange bit are really worrying, which is what is concerning. And then one needs to start thinking, why is that happening? And it may be happening because we are possibly ignoring or have ignored, which has come up in the last 5 to 7 years, the femoral anteversion aspect of it. And we really need to ensure that we are actually measuring the femoral anteversion in all the cases. That's one aspect of it. We need to get smarter with our preoperative assessment. So we really need to make sure that the patients who've got arthritic change are actually not put on the list, even if they are Arthronis 2, and we've clearly shown that in multiple studies. And a way out may be this volumetric assessment of the joint space, which can actually tell you that these patients may not be ready for surgical intervention if that is reduced significantly. Aspects like this, where you have got dynamic MRI scans to look at the impingement lesion, are around, and we're doing some research analysis on this. And then 3D planning based on models can also be helpful in allowing us to define where exactly the deformity is, especially in the cases of complex deformity. So the first thing was we needed to look at what exactly is the normal head-neck junction before we define excision of the cam. So we use statistical shape modeling to define what exactly is the normal head-neck junction through principal component analysis. And now we can actually define what is normal, what is abnormal based on this morphological structure, and be really taking that out only. The other aspect where technology comes in is discrete element analysis, which is essentially pretty much like finite element analysis, but it measures contact stresses in the joint on this occasion. So this journey for me started almost about 10 years ago when we looked at navigated hip arthroscopy to make our intraoperative execution perfect. And we did cadaveric experiments. And the first thing we wanted to check was imageless versus image-based registration for navigated hip arthroscopy. Clearly, at that time, the image-based navigation was much better. So we translated that into a clinical trial of 30 patients navigated versus conventional hip arthroscopy, as you can see here. And clearly, the patients in the navigated arm did much better, especially in the 12 o'clock position excision. Then what we did was take all those patients who had perfect excisions of the cam lesions and subjected them to a technique called discrete element analysis and basically measured their contact forces. And it clearly shows that if you do an accurate excision of the cam lesion, then basically you're going to have reduction or normalization of contact forces, which is a very good surrogate marker to suggest that if you did perfect surgery, then you're preserving that joint and hopefully preventing arthritis in that patient. So along with what Femi showed you in the natural history paper, this is the lab data with DEA, which clearly shows that if you do perfect resections of your cam lesions, then you get normalization of forces out there. And then there are tools available like this with Stryker, the hip check output, which you can actually keep checking your alpha angle in different positions as you do your excisions. So we realized that with navigation, it was pretty much cumbersome to have these big machines in the operating theater, the navigation machine, the 3D fluoroscope, and we needed something smaller. And then the thought process of the robot came in. So we basically looked at the Franca Amica robot, which is available commercially. And we wanted to see if we could use that by feeding data into the robot to excise the cam lesions. And this is what it's able to do. So here you are. We created a very large portal out there for 5 centimeters, but it's the same shaver, the Stryker shaver, a 5.5 millimeter burr. We told it how much to resect in terms of depth and also the area. And the robot basically is doing that for you at a 30-degree angle. And this is fairly rudimentary in the lab. And what you get is a beautiful finished surface like this. So it's not difficult to conceive that this would be probably the standard of care in the next few years, as it is for prostate surgery or for joint replacement surgery as well. So the next steps for us are basically to take the Stryker collision analysis model, feed that into the robot, and use this sawbones model, followed by cadaveric testing of this robot to excise cam lesions accurately. Obviously, what we are getting towards is a personalized and accurate resection of femoroacetabular impingement. Obviously, very expensive at the moment and only in the research stages, but not difficult to conceive that this would be the standard of care in the next few years. So you take your X-ray, you take your CT scan, get your collision analysis model, get your version measured appropriately, get biomechanical data, feed that in, and get the resection done accurately. So that's where we are heading. And it's not only about morphology, it's not only about creating a perfect sphere, but it's actually about making sure that the contact pressures, the contact forces in the hip joint are normalized, because that's what we are aiming to achieve with all these resections. So that's preoperative planning and intraoperative execution. Finally, we have postoperative assessment, and basically we're doing a trial on rehabilitation now and also physiotherapy. So using this tool, this app, both to deliver physiotherapy and also to monitor compliance in these patients. And that's where technology could be extremely helpful as well. And finally, with our own registry data of over 22,000 patients, looking at machine learning algorithms to see if we can actually predict the MCID in these patients much before we actually start operating on them. And that is already happening, and we published that from our own registry. So that will allow you to predict which patients are going to do better or not. And based on this, we've got a whole technology research program which looks at optimizing outcomes for hip preservation surgery, both looking at surgical risk factors in terms of stratification of disease and outcomes, and then navigation and robotics, and then non-surgical factors where muscle strength and prehabilitation play a big role as well. Obviously, you can't do this alone, and you really need a great team to be actually working behind the scenes to help you and to work with you and collaborate with you to actually produce this. So big thanks to them. And it's fairly exciting. I'm really excited by the opportunities that exist in terms of technology in hip preservation surgery with automatic segmentation, calculation of angles and indices, stratification of disease, looking at the role of muscle strength in the pelvic tilt. Genetics is another big area. We're doing some single cell analysis work on that with phenotype and type correlation. Robotic arms you've seen already for precision surgery, and then AI as well you've seen for developing prognostic algorithms, and we've done some work on that already. The message I would leave all of you with is collaboration is definitely the new competition. So if you really want to do good things and big things, you need to collaborate with smart people around the world to deliver this pit stop in 1.82 seconds. Don't do it alone. Thank you very much for your kind attention.
Thank you, Vikas. Amazing talk. Thank you so much. This is a good example for the pit stop. Hopefully you could do the same with the football team in the Euro Cup.
You are definitely obsessed with football, Oliver.
Yeah. We are, we are now focused on that. So let's do the discussion. And Klaus, can you lead this discussion? All the faculty are invited to join us.
Yes.
During the discussion. So please.
Yeah. Please open your video so we can see you, who can join the discussion. First, thank you very much for this excellent and exciting talks. There's a large field, open field for questions, I think. And I would like to invite also the audience, put forward your questions to the screen, or you can have the audience chat and bring forward to your questions, and Oliver will work on that. In the meantime, I want to ask Michael Wettstein. So you were showing difficult cases of hip joint deformities for open hip surgery. I think for me it's rather clear to have, when you have large deformity like a Perthes disease or whatever, that open surgery is the key. But where is your limit? Where do you separate whether to do it arthroscopically or when to change to open surgical hip dislocation?
I think an anterior deformity of the femoral head neck junction going up to the lateral synovial fold, maybe a little bit above. This becomes more difficult, but is feasible. A deformity which is a bony position at the anterior rim of the socket, with no posterior inferior impingement, I would go for a hip scope. If I have more deformity, I feel more comfortable doing a labral plasty in an open way than arthroscopic. All the more if it's an extensive plasty, then I prefer an open surgery.
So how do you define extensive deformity? Do you use like sophisticated imaging, like CT as a rule, or MRI? Or how do you define what is extensive? What can I reach by the means of an arthroscope and whatnot?
Well, for the acetabulum, I look mainly at the X-ray pictures which show the bony deformities quite well, I think. The discussion now is open whether we need CT scan. If I'm in doubt, I use CT scan from time to time, but mainly I look at the X-ray pictures. For the femoral deformity, I think the radial sequences of the arthro MRI are quite useful, and this shows you the lateral synovial fold, medial synovial fold, and you have a really good view of the 3D shape of the femoral head neck junction. And this is my landmarks and geographic map to surgery.
So would you advocate that all patients undergoing hip surgery for a femoral acetabular impingement should have an arthro MRI beforehand?
Well, it depends, because in certain countries, arthro MRI is not easily available. In France, for instance, they do arthro scans, which gives you plus minus the same imaging. I'm used to arthro MRI because it's easily available in Switzerland. And for me, I wouldn't go for a hip preservation surgery without an arthro MRI or arthro scan.
Yeah, I think that's, I do share this opinion. As far as it goes to surgery, if you start a conservative treatment with physical therapy, whatever, I still might stand back with more sophisticated imaging. But I think once you make the decision now, it comes down to surgery. I think for me, for us in Bern, it's decisive, it's important, it's mandatory to do a sophisticated imaging in order to know where's the deformity on the femur as well as on the acetabulum and what should be done. I would like to convey this question to Vikas, who has very sophisticated methods of 3D imaging and navigation, which is very, very impressive. So what's your rule? What do you need before performing surgery?
So mine is very simple, Klaus. All patients get an AP and a done view when they come in. If they are being considered for surgical intervention, most of them have had an MRI outside already. So I don't repeat the MRI, but I definitely do the CT scan with 3D recon with cuts at the knee to get their femoral version. So technically all patients will have an X-ray, 2 views, MRI, and a CT. And just to add that we've just done a fairly extensive consensus statement for hip and groin pain with ESMA. And even in that, after 20 months of research and consensus, we've come to the conclusion that your primary investigation would be your AP and cross-table lateral or done view, and your secondary investigation should include MRI and or a CT with slices at the knee to get your femoral version. So that's mandatory, as you say, if the patient is being surgery.
Well, I would fully support this, because you may miss a lot of information just being based only on an MRI or only on conventional X-rays. So I think this is really mandatory.
May I ask you, Klaus, something? I mean, about do you think this technology that Vikas present us could help you very much with the PAO, for example? I mean, what do you think about these new technologies in PAO? Because under my thinking, I mean, I think this is the best surgery to be improved with this technology.
You mean with 3D, with navigation, or whatever? No, sure. I'm very happy to see Vikas Khanduja working on this field. He's much more advanced than we are on this imaging field. I think that's the future. It will reduce stress on a surgeon, and it will allow us to be more accurate in cuts and also in reorientation, or in defining what we have to take down, which amount of cam deformity we have to do it, which amount, or if at all, we have to trim a rim, for example. So, and one very important issue also was that we have to measure torsion in all patients undergoing surgery. You need to know whether there's an additional problem. Oliver, do you have a question from the audience?
Yes, I have some questions. So
in the meantime, I would like to add that according to when you decide what image do you need for doing your surgery, if it's enough with a regular MRI or you need an arthro MRI, I think that it depends on the radiologist, the machine, and the fine tuning of the machine. Sometimes you see a 1.5 magnetic resonance without contrast that you see clearly what you want to see. And sometimes even with a 3 Tesla, you cannot see nothing. So it depends on several things. And if I have an image that I can see very clear, I don't repeat. But if it's not good image because of the machine, because of the fine tuning of that machine, or because of the radiologists have not done proper work, I think you should repeat. And it's not a problem if it's an arthro MRI or a 3 Tesla without contrast. It depends on those 3 factors. And if you have control of those 3 factors, then you can have a good image with even with a simple 1.5 Tesla without contrast.
I don't think it's the machine. It's the man or woman behind it. And you have to train or torture your radiologist until he really provides good images.
Well, I think it's the 3 things, because with a 1.0, you cannot see nothing. If you have a 1.5, but they use a body coil, then you will see nothing. But if they use a proper coil and the radiologist knows what he's looking for, maybe with a 1.5 Tesla, you can see quite well images.
Yeah, this is a message from Ecuador, because is this technology will be available for the low-income countries? I mean, is it expensive, and when do you think could be available for the whole community?
I mean, I think technology is expanding at a very rapid rate, and it's becoming cheaper as we go along. So the Franca Amica robot that you saw was £25,000, and already in 2 years' time, the prices have come down. So the short answer to the question is, I would envisage that in the next 5 years, a lot of the big centers would be using this technology, which would be quite cheap, especially people who are doing Mako already, and they have robots in their hospitals, will definitely be jumping onto this to get at least the preoperative planning aspects of it right. And some people would be using it for intraoperative execution as well. I think the challenge would be, like you said, the PAOs, because we still rely on a fairly rudimentary intraoperative plain radiograph in theater to see your correction. If you're able to use DEA for looking at contact forces, and then for intraoperative execution use not robot, but jigs, and they're already out there, as you know, then that would make our procedure much more reproducible. And like Klaus said, it would definitely lengthen the surgeon's lifespan as well.
Yeah.
Wonderful.
Yeah. Oh. I have one question to Dr. Ayeni. I think
Ayeni is not here. Ayeni is not here. We can reply you if you want.
Okay.
So, Klaus,
maybe Vikas can. Oh, sorry. Yeah. Up to you.
Maybe we are late because we have some delay. And remember that this is a virtual webinar. We need to be on time. So thank you, guys. Amazing discussion, amazing talks. Let's move to the next block. So the next block will be, you see, I'm obsessed with this Euro Cup, but in 3 hours, there will be a match Spain-Italy. So we have this Crossfire, Spain versus Italy. And please, Marc Tey will talk the first talk in favor of preserving surgery in moderate osteoarthritis. Marc?
Hello. Thank you very much, Oliver. Let me see. Thank you very much for inviting me to that meeting. And I will talk in favor of doing preserving surgery in moderate osteoarthritis. But let me start with something that we usually have in our clinical practice. We have patients that frequently ask those questions. Am I in time for an arthroscopy or should I go to arthroplasty? Or another question that is very common, I have osteoarthritis, but I'm very young. Can we do an arthroscopy? Or I'm afraid of arthroplasty, could we try arthroscopy? Those are very common questions. And I think it's important to make clear to all our patients that we cannot mix pears and apples. When we talk about arthroscopy, we're talking about a particular approach to the joints. Like it could be an anterior or a posterior approach. But as the main thing, we talk about arthroscopy when we are talking about preserving surgery, in contrast to arthroplasty, that is the replacement surgery. So if we want to compare apples with apples, we are talking about what are the limits of preserving surgery. So the real discussion is where are the limits of preserving surgery and where we should stop. And I will try to convince you that sometimes we can go for preserving surgery with a degenerative joint disease. And it doesn't depend on the age. It doesn't depend on how old is your car that you have to change the wheels. It depends on how waste are the wheels. So what happens when you have a young patient but with a degenerative joint disease that probably needs to be changed, but you are in those limits of preserving surgery? That's the topic. And I will show you two cases that will help us to the discussion. One, it's a 32-year-old man. It's young, not too young, but young. He's a soccer player, crazy with soccer, like Oliver. And he has sport-related hip and knee pain. With a clinical examination that it's similar to the clinical examination that you can have in femoral acetabular impingement syndrome. But in the X-ray, you can clearly see that there are some osteophytes in the femoral head with a quite well preserved joint space. In the magnetic resonance, you can see that clearly you have osteophytes in the femoral head, and the joint space that it's relatively preserved. And we did a scope, and that's what we found in the scope. We have detached labrum, but we have a huge cartilage lesion. Even that, we did our surgery. We repaired the labrum, and we resect that osteophyte. And we try to restore the sphericity of the femoral head. Here you have the videos of our surgery where you can see that it's not a healthy cartilage, what you can see in the femoral head. But finally, we get those X-rays. And 2 years later, those are the X-rays. You can say that they are, well, not that bad. But there's nothing worse for the outcomes than the properly follow-up. And if you follow up that patient for more than 2 years, then you will find that finally the osteophytes are here again and the patient increased. And finally, this patient needed a hip replacement. And he was not satisfied with his surgery. He was looking for something more stable. So that was a bad result, probably based on a deficient evaluation of the initial onset. But here you have another case. This is another 32 years old. He's a professional soccer player, but he cannot play soccer for the last 1 year because of his pain in his hip. Similar examination, and here you have the magnetic resonance where you can see clearly that he's a good candidate for total hip replacement with a small joint space, osteophytes, and all the typical signs of osteoarthritis. But we went to, after discussing with him, we went to surgery. We did a labral repair, but you can see the huge cartilage lesions that he has, and you can see the huge cartilage lesion that he has also in the femoral head. Here you can see them. And we did that surgery. 6 months after the surgery, the patient was able to play soccer again. 1 year after the surgery, he had a new contract. In those 3 years since the surgery, he had a good money playing soccer. And 3 years later, with this magnetic resonance, he needed a total hip replacement. But this patient was really happy because he was looking for 1 year of playing soccer in order to have his last contract, and he could play soccer for 3 years. And this is the amount of money that he won in those 3 years. So he was really happy. So the limits probably are not related to the degenerative joint disease, but they are related to patients' expectations. And I think that is the important measure. We can have different modes of failure of our surgery. In the mode 1, where there is a disease progression, it depends on patients' expectations. If we know that there is an arthritic joint and we are trying to advance a little in our case, it can be a good idea. So it depends on the expectations. On mode 2, incorrect initial diagnosis, that is what we have to go against. And that means that we have not done a proper diagnosis, or we cannot explain a proper diagnosis to our patients. Mode 3, it's improperly performed surgery. Those are difficult surgeries. And that means that you need experience, you need to be very scheduled to do those surgeries. But of course, we can have always unexpected consequences. But in order to manage this case, mode 1 is mandatory. You need to manage expectations. So I think the limits of preserving surgery depends on patients' expectations more than the particular diagnosis. Thank you.
Thank you, Marc. You have a yellow card because you used 2 minutes more than your opponent. So, Nicola, it's your time, please.
Okay. Here I am. Thank you. Can you see me? Yes. So my topic today is to talk against, but I will talk mostly against the idea that this is preserving surgery. What we mean by moderate OA? By moderate, for the purpose of this talk, I mean the arthritis, the damage that is visible on conventional X-ray, especially on standing X-ray. If it is visible only on MRI, we are talking about chondral damage, not moderate OA. Moderate OA, in my mind, open hip preservation is out of question. Therefore, we are talking about the possibility of arthroscopic hip preservation. That would imply improving symptoms and preserve. But if we look at the literature, in these studies, for example, this one from 2024, when there is already damage and we do surgery for femoral-acetabular impingement, the rate of conversion to total hip replacement, it is really high. And again, the group of Parvizi, 12% conversion rate. And when they looked at the risk factors which were producing failure, the degree of damage of the joint was by far the most relevant. This is a case of a typical active patient with moderate signs of osteoarthritis. The patient is 24. She's a professional dancer. You can see on both AP and Dan view that she already has some significant damage. She was scheduled for bilateral hip arthroscopy On the right side, good correction, microfractures because of an extensive damage. This was 2011. Few months later, she underwent surgery on the other side. As you can see, with the joint was in good shape. We all know this kind of patient. They are very, very active, very motivated. This is her doing rehab 2 months after surgery. This patient, unfortunately, they don't accept the idea of slowing down. She was advised that the right hip was at high risk, but no matter, she went back to professional dancing. She was pain-free, very good results. But then she came back 7 years after that, at age 31. You can see advanced osteoarthritis, and 2 years later, she underwent total hip, whilst on the other side, as you can see, the joint is still preserved. So on one side, we obtained relief of symptoms for 5 years, and the patient was happy. On the other side, we obtained both relief of symptoms and preservation. So how should we decide for surgery in this kind of patient? Well, the most important thing is the load distribution around the joint. We heard from previous speaker talking about that. Once we have impingement, we have damage on the periphery of the joint, and if this goes on for too long, that's involved damage of the joint. When the joint is damaged, the head starts migrating because there is no longer acetabular cartilage. The stresses get more and more concentrated in a small area of the joint, and no matter what you do, this joint is gone. It's going to proceed to osteoarthritis. So when we have such cases, we shouldn't talk about preserving surgery, but about the decision whether to do palliative surgery. In fact, we can correct the bump, we can restore some degrees of joint motion, but we won't change the history of this joint. Therefore, it's important to profile your patient, understand the amount of symptoms in daily life, understand and talk about what happened if they have tried to give up sport, how much the situation has improved, and the expectation, because most of these patients, they want to go back to sport and to go back to full-time activity of sport. And unfortunately, this is producing failure. Do we have any evidence that hip arthroscopy is superior to simply lifestyle modification? If they accept to slow down, do we really know that this patient have a benefit simply from arthroscopy, or is due to lifestyle modification? I don't think we know. It's also possible that if we relieve symptoms, as I did, for example, in this case with Costanza, she went back to dancing and possibly she ended up by shortening the survival of her hip. Therefore, select your patient very carefully, and I don't think we should use the word preservation in such cases. Thank you for your attention.
Thank you so much. So we have now time for discussion, and after that we will have the voting. So Klaus, can you lead the discussion? Please ask very compromised questions to these two speakers. So.
Yeah, okay. Well, first question to the second speaker. To Italy. Actually, your talk was more or less in favor for doing it, instead against. At least you did surgery on a case where I would not do hip joint preservation surgery. And you suggested it's for lifestyle or for the expectance of the patient to get a prolonged life in dancing. I think it's the wrong way to approach this problem. The question is whether we can help to preserve the hip joint. There is no palliative surgery for me. Either I can preserve it, so the lesion should still be okay. We should not have osteophytes and should have a reasonable young age. The reason why your patient did better on the right, on the left side than the right was simply because she had less cartilage lesions. So I don't. I think one step is to decide it has to be real joint preservation. The second is lifestyle has to be modified, or as a doctor you have to recommend this. Whether the patient does it or not is another issue. No, it's up to the patient.
No, I fully agree.
I'm not a lifestyle surgeon.
No, what I mean is that when we have a moderate OA, meaning that the head has already migrated to some degree, this is no longer hip preservation. You can possibly improve symptoms, but what changed the survival of the joint, I think it's mainly if they accept to slow down with their activity, especially if they are professional athletes. I don't think we cannot say that the joint survived longer because of our correction, rather than. I don't think there is no evidence. There is no literature saying that. Okay, you do correction and you obtain a longer life for the joint. I think we relieve symptoms. Okay. I don't think we improve the survival of the joint. Therefore, I am very cautious to advise.
Can I say something?
I give the word to you. Yeah.
Can I say something?
What's your opinion? Yes.
Klaus, you are the lawyer of the hip.
Yes.
And as a lawyer of the hip, you recommend not to do any surgery. And that's good. But I am the lawyer of the patient, not of the hip. So I'm taking care of the expectations of the patient, not of his hip. So if the patient understands the price that he is paying, I think it's allowed to do that. But as a lawyer of the patient, as a lawyer of the hip, yeah. For sure.
Yeah, yeah.
No question. Yeah. It's about indication.
No. I think you cannot separate, but the basic is true. I'm the lawyer of the hip. But then the patient's expectations have to fit to match reality. If I cannot promise to do, if I don't have reasonable arguments that my hip is joint preservation, that means 10, better 20 or more years life, which we all do not know exactly. But we know data from Bern, 80% after 10 years have a well-functioning hip joint. And we know already that the osteoarthritis is a key factor. Osteoarthritis, we have to talk about the degree, grade 2, grade 3 tennis is very difficult. Is basically not a good indication for doing hip joint preservation. So being the lawyer of the hip is also being the lawyer of the patient, because the patient will be unhappy afterwards with an unhappy hip.
But for example, the case I've shown, the patient, she was extremely happy. She went back, she danced, but at the end of the game, at 33, she had the total hip.
Yeah.
I'm not happy as a doctor of these results.
Neither me.
Neither me. But I don't think I could have done anything better than that, because the correction was perfect, and I don't know. What would you have had done something different?
I mean, it's amazing, guys. You are fighting a lot. That's the objective of this session. Yeah, but you know, we got changed from football to lawyers, judges, and these different things. But we have to finish, so we need to vote the winner. I mean, remember that the winner will get a prize, probably a bottle of Spanish wine. I don't know. So, but you need to vote. Marc Tey from Spain in favor of this surgery in osteoarthritis, or Nicola Santori against to do this surgery in moderate osteoarthritis. Please vote from the audience. Just click on the screen and we will get the vote in a minute. So please vote. I mean, Marc, you cannot vote. I mean, You're not allowed. And Nicola, you as well.
I tried.
Right? So, yeah, they're trying to click the vote and it doesn't work, right? I know you. I mean, I know both of you. You know? So, do we have the results in rate? Yeah. So the winner is Nicola. So yeah, Nicola, congratulations for winning this battle. I hope
well for tonight.
Yeah, I hope the result will be different tonight. Okay, thank you so much, guy. And let's move to the last part of the session. Keep connected for the discussion of the case that Pedro Dantas will present the case discussion with some questions in the middle that the audience can vote. So please, Pedro, go ahead.
So thank you very much for the kind invitation. So we present a case of a young footballer with groin pain. And this is a 23-year-old footballer that was complaining with left groin pain for the last 6 months. There was no previous complaints or no any major trauma. On the physical examination, she had a limited internal rotation by 0 degrees, and the external rotation was 35 degrees. The FADI, which is the flexion, adduction, and internal rotation test on the dexterate, was positive with anterior pain. So this is we could reproduce the pain with these movements. There was also a leg length discrepancy with the left lower limb longer than the right lower limb. So these are the X-rays. So there was an increase of the off angle, which is this angle that measures the sphericity of the femoral head. There's a bump at an decreased offset on the femoral neck. The lateral center edge angle was 27 degrees, that was within the normal range. And the neck shaft angle was 132 degrees, that is normal. So we moved to advanced imaging. The patient had already a CT scan, and we can see a cyst on the anterior superior femoral head that we can see in these 3 projections. We asked for a 3-tailed MRI without contrast, and we can see that there's a cartilage defect on the femoral head, and also in the sagittal cut, you can see the cartilage lesion on the femoral head, and on the frontal plane there's some edema underneath this cartilage defect. So there was also some damage on the chondrolabral junction that we can see, and then we can discuss with the clinical examination and with this X-ray imaging findings what is the right diagnosis. There are 4 options. I think we can vote now, and we can have it's open to discussion too.
Okay, let's discuss and give time to the audience to vote the 4 options for diagnosis. First option is FII. Second one is traumatic osteochondral lesion of the femoral head. Third option, osteochondral lesion of the femoral head due to childhood disease. And finally, FII and osteochondral lesion of femoral head. So while the audience is voting, I would like to ask all the panelists. For example, Marc, what do you think? Which option is for you?
Well, FIIs, it's not something related to the image, it's something related to the biomechanics. So I think that the diagnosis of FIIs must be based on your clinical examination of the what the patient explains to you more than the image that you can see. On the other side, in the image, you can find an osteochondral lesion, and it can be related to the trauma that you have in that joint during the impingement, or it can be associated because of another complication. But I think that you should understand that the FAIs, it's not just related to an image, but it has been related to an examination.
Yeah, interesting, Mark, but which option do you choose from these four? So
I think that he probably has an FAIs and you have an osteochondral lesion of the femoral head.
So option 4, right?
Option 4.
Okay. So Michael, what do you think?
I would say 4, but there are some missing informations. How was the apprehension test? I mean, he has an increased femoral torsion. It's not catastrophic, but it's increased. And this lesion, for me, rather looks like anterior instability lesion than impingement lesion regarding the cartilage.
Thanks. Nicola, what do you think?
I would say for option number 4, I'm not sure about the origin of this chondral lesion. I would say is a relatively negative prognostic factor.
Okay, Klaus, our mentor,
Yeah.
what do you think?
I would say it's 4. It's untypical to have a lesion or a cyst there just from pure impingement. It could still be related to impingement, but I think it might be osteochondral lesion and impingement. So impingement, I can only say it's a cam deformity or lack of offset. I would need to know torsion, femoral torsion. I can tell from standard views. And I have not really seen acetabular coverage. It was a little bit too fast, but I think it's more or less normal. So it's cam deformity and this lesion and the cartilage defect.
Okay, let's see what the audience think about that. So can we see the results of the poll? Yeah. 70% said 4. Okay, amazing. We agree, all of us, attendees and faculty. That's perfect. So we are talking about, there are some information that would need. So Pedro, can you continue with the case and maybe show us some information?
The apprehension test was negative. The femoral torsion was 30 degrees. I think this patient has clinical and also imaging findings of femoral impingement, but the location of this osteochondral lesion on the femoral head is not typical. So we can move to the treatment. So these are some of the options that we can discuss. One is conservative treatment without football playing and a shoe raise because the left lower limb was longer, an intra-articular injection, an hip arthroscopy with femoral osteoplasty and microfractures of the femoral head, a surgical hip dislocation, femoral osteoplasty and mosaicplasty, or a proximal femoral osteotomy to unload this area of the chondral lesion.
So it's very interesting. So let's ask the speaker, the faculty, Nicola, what do you do in this case?
I've done a few cases similar to this, and as I said, I've not been fully satisfied because. So possibly I would go for option 4, surgical hip dislocation and mosaicoplasty. I think we need to take care of this chondral damage.
So you change from arthroscopy to surgical hip dislocation. So, Michael, you have one follower. What would you do?
As I said, there are some lacking informations to decide. With what we know, I would go for something between 4 and 5, probably a combination of 4 and 5.
Okay. So, Marc?
In my opinion, and with the limited information, I probably will not.
Marc, do you need more information? Which kind of?
But anyway, I will not go for any kind of microfractures or mosaicplasty because I think that you have lesions in the femoral side and in the acetabular side. And when you have a mirror image, it's not a good idea to do any kind of chondral procedure. So probably I will do just conservative treatment, changing his habits, stopping football. I will be a lawyer of the hip in that case. to decrease the activity, and then we will see. But I don't think we have a really good option to trade that joint.
So, Klaus,
Yeah.
you are the judge. I mean, you are the judge or the lawyer, or I don't know what.
I remain a lawyer of the hip, so I agree. He should. I would recommend to stop football. I know that a lot of people don't want to do it, but it's their decision, not my decision. They want an advice about
play hockey. And play hockey. What?
Yeah. Well, no. Swim, bicycle, do something like this. You know.
Okay.
Not high impact sports. That's one thing. That's one pillar of treatment. Then he's young, he's 22, 23. He has beginning cartilage damage. So I would need a 3D information about the extension of the cam deformity. I would treat the cam deformity, either open or with hip arthroscopy, depends on the extension. And I do think the lesion of the head is too small to do like a mosaicplasty or something like that. I might rather do just like a picking, microfracture or drilling, if at all visible during surgery.
Great. So let's see what the audience said about this treatment. So most of them choose hip arthroscopy, femoral osteoplasty, and microfracture, 39%. And there is 28 that select this conservative treatment, doing like a lawyer of the hip.
You can do both. You can do both.
Yeah. And then 28% said surgical hip dislocation, femoral osteoplasty, and mosaicoplasty. So interesting. So Pedro, what did you do in this case?
This patient was off football for 6 months, and still with that, he was with pain in the daily activities. So what we've done an hip arthroscopy. We can see that there are several loose bodies intra-articularly. There's also, you can see in a few seconds, damage of chondrolabral junction.
Yeah.
And there's a cartilage defect on the femoral head. This area is very difficult to assess with microfractures. And I don't think we could manage to do a good job like that. So in the same setting, we advance for a surgical hip dislocation. This is the femoral head lesion. It's around 2 centimeters by 1.5. We remove 3 osteochondral grafts from the cam area. We put the osteochondral grafts in the defect, and we perform femoral osteoplasty. And this is the intraoperative X-ray. And we have a 2.5 years MRI, follow-up MRI. Patient is pain-free. Get back to football, because despite my advice, I think this hip won't last forever. And on MRI, it might show some reconstitution of the cartilage, and there's some decrease of edema underneath the bone.
Yeah, fantastic treatment. Any comment on that?
Congratulations. Yeah, good done. Well done.
So, Klaus, any comment?
Yeah, I said well done. I think I have to compliment. Also, it's not easy to make the decision to switch during surgery, but if you have a good talk to the patient beforehand, you can say, if I need to do more treatment during surgery, like derotation or like osteochondral graft, we will open the joint. That's very good. Compliment.
So, Michael, what's your topic? What do you think? You won.
Are you talking to me, Oliver?
No, Michael. Michael is
Michael, sorry.
For surgical dislocation. You are mute.
Michael Wettstein, you mean? Yeah.
Yeah. You're mute.
Yeah, sorry, my mic was not on.
Yeah.
Looks great. I think that's the best solution for him. The question is how long it will last. But actually, he's happy. Back to his sport. As Klaus said, it's the patient's choice. We can just advise them. But looks great.
Okay. There is a question from the audience, guys. I mean, let's reply the question from M. Nihoff. They said, extension of the cam influence your choice between scopy or open? what is your cutoff point regarding extent of cam deformity? So any comment on that? I mean, Nicola?
Yeah. That's a very good question. This is why I do insist on radial MRI cuts. So I see exactly how much area the cam deformity takes. So if it goes, we call it 11 o'clock position. If it covers actually the retinaculum with blood vessels to the head, which we call 11 o'clock, 10 o'clock posterior. If it extends to that area, we do it open. If it's up to more or less 12 o'clock, we do it arthroscopically.
Okay.
But this is only the decision for cam deformity. If we plan to resect the rim, the acetabular rim in front, anterior rim, we also do it open.
So any last comment, Nicola, for example?
I personally do a lot of dynamic movement during the operation, and therefore my template is the acetabulum, and I managed to relieve the impingement, and therefore you have to take time. It's a long operations, and but the key point in my hands is to move extensively the hip and the direct visualization and achieve the best job possible.
Thank you. Marc, one last comment because we are out of time.
I think that you can advance in management of non-usual deformities if you manage different portals and you have patience. And I think that you can do much more than what you initially think with hyperarthroscopy, and not just the classical cam morphology between the synovial fold and within the lateral synovial fold and the medial synovial fold. I think that you can extend if you adapt the portals to that particular area.
Thank you. Any other comment, Michael, to close the webinar? Michael Wettstein?
Yeah, well, I think what Marc just said is right. What you do depends on your experience, and I mean, as hip surgeons, we should have all the tools in our pocket and choose the best tool for every patient. One single tool doesn't work for all patients.
Thank you.
Can I make a comment, Fano?
Yes, sure.
So the idea here is not to bring the patient back to football, is to decrease the amount of pain, and decision to going back to football is up to the patient. I think this highlights what a hip surgeon should do. He should manage to do an hip arthroscopy, check the joint, because if the patient had a significant acetabular chondral damage, probably this mosaicoplasty was too much surgery for him regarding the prognosis. So this is what I would like to highlight.
Thank you, Pedro. So to close the webinar, Klaus, can you say some last words?
Well, I think, sorry, I think it's very important to stay in discussion about it. It's not only about is it arthroscopically or is it open surgery. It's how do we do the accurate diagnosis, and I would really promote to make the diagnosis in full entire correct with 3D imaging, either CT scan or MRI scan.
Thank you so much. So thank you, everyone, all the speakers. Thank you, European Hip Society, for promoting these webinars. Thank you to the audience to participate in that. We have the next webinar just in September, so please enjoy your summer and enjoy tonight the match against Spain against Italy.
We will.
Let's see who will win the Euro Cup. So thank you, everyone, and see you in September 19th, Thursday, about primary total hip replacement. Bye. Thank you.
Bye.
Bye.
Thank you.
Record.